and transcribing?
Oh, yep, there it goes.
Yeah, it does show up.
Okay. So if you want me to, I can leave it on, or I can stop it now and then start it in just a minute.
That's fine.
Okay.
Whichever way. It's just this way I can take my notes and refer back to that transcription in case I miss anything or I misconstrued anything. Then I have those notes to go back to if I need to take anything back.
Thank you so much, Monique.
No problem.
And Beth, I'm going to leave it on since there's like 2 minutes, if you're okay with that.
I'm fine with that. Thank you, Marcel.
Okay. And I can let people in after. Tell me whenever you're ready, or stop doing it after 9.
You can do it till your heart's content at 9 o'clock.
Okay. All right. Are you ready?
Oh, yeah, yes.
I'll come off with you too, and I'll admit all.
Good morning.
Hello.
Morning.
Good morning.
Good morning.
Morning.
Thank you guys for giving us time this morning again so that we could gather and as we work through provider type 93. I appreciate it. We'll give it just a couple more minutes. It just reached 9 o'clock. We'll give it just another minute or two. Okay. It is 9:02. So we will go ahead and get started. You all have probably seen there were some questions after our last meeting, inquiries about the recording. Last meeting did not get recorded. My apologies. This meeting is being recorded, so that will be available as well. So I just wanted to say again, good morning. For those of you who I have not met yet, my name is Beth Scott. I'm the policy specialist over provider type 93 and the SUD 1115 waiver and with the behavioral health unit. Again, thank you for rearranging your morning to spend time with us as we resume the provider calls to provide support to our substance use treatment team. Quick reminder, this meeting it should be ongoing on your calendar. It should be standing for the second Thursday of the month. If you need an invite, please reach out to the Behavioral Health inbox, drop me your email address, and I'll be happy to get you added to the invitation. The agenda was sent out a couple of days ago. It should be attached to the invitation on your calendars for this. And we have a large group this morning, but you're more than welcome to use your chat. You're more than welcome to come off mute, raise your hand, just so that if you want to talk, just make sure we're raising our hand so that so our microphones aren't competing and we're talking over each other. But feel free to use the chat or to verbally talk so that we can have some meaningful discussion. With that, we'll take roll call. DHCFP is on the call. Gainwell Technology, are you guys on the call?
I'm here.
Okay, thank you. Good morning, Susan.
Good morning.
We have DPBH representation on the call.
Good morning.
Good morning, Abe. Thank you. And our MCOs, are MCOs on the call today? Okay, I didn't think so. The MCOs were not able to join us today. They've asked for their questions to be emailed to the managed care inbox. They are anticipating joining us next month. They had a prior commitment that they were not able to join us today, unfortunately. Okay, so I'm going to share my screen just so that we can go through the agenda together. And I liked the format. If it didn't work for you from last time, let me know, but I like the format of being able to make notes in real time as we were talking about it and then send that agenda back out to everybody. So if you have any other suggestions, I'm open to hearing them, but I think that worked well. It worked well when we had to send the questions out for other people to answer answer for us as well. So starting on to item number 2, are there any accomplishments or any accolades that anybody would like to share with the group? Any good things happening? Okay. Then following up from last meeting, there were a couple of questions that I received afterwards, and I just kind of wanted to start there. With regards to data collection, there was a lot of confusion about when this is supposed to start and what's happening. And so I just wanted to clarify that as of right now, there is no time frame when the data collection is to start. DHCFP's current position with CMS is just to engage and start the conversation with providers to develop the process in which the data will be collected. So that's what we're doing, right? This is that conversation. The data collection specifically that we talked about, the 4 items from last week, they are being pulled. That data specifically can be pulled by claims data and the HEDIS measures from the MCOs. So I also wanted to clarify there was some concern that there was going to be a lot of extra data collection, and that wasn't the intention. It was more of just a discussion of is there other data that would be helpful to collect. But I understand that we're not there yet. And data collection is specifically for the 1115 waiver. So it's specifically for those who are providing the residential substance use treatment. Okay. Last month, a provider had asked if we could, for the definition of plan all cause readmission. Essentially, this is just a measure used to assess the percentage of hospital stays that end up in an unplanned readmission within 30 days. Again, this is a HEDIS measure. It's pulled, the MCOs are tracking that. The MCOs last month were not able to be present. There were a lot of questions for the MCOs, but the feedback that I got from our managed care quality assessment or quality assurance team is that DHCFP met with MCQA and met with the MCOs to address your questions and concerns from our last meeting. Draft billing guidelines were provided to the MCOs, and they agreed to transition over to and the MCOs agreed to transition those providers based on the draft billing guidelines. MCQA has arranged for provider enrollment to compile a list of provider type 93 reports on a weekly basis. And they will share this with the MCOs weekly until the system is updated. So I wasn't at that meeting. Unfortunately, I was unexpectedly out of the office. And but what I understand is that the DHCFP, MCO, so the question is who has oversight of the MCOs. So the DHCFP side of the house that helps manage the MCOs, they are going to work with them on a weekly basis until we get everybody transitioned. Please continue to email your MCO questions to the managed care email address, policy questions to behavioral health, and your Gainwell questions. Sure. Esther, go ahead.
This is Esther. Okay, so it rolls very well off your tongue, but could you call out what you mean by MCQA, DHCFP? I mean, MCO, we get it. But
okay.
Would you, before we go on, because it's a little confusing.
Thank you for asking, Esther. So DHCFP is Medicaid, right? That's us. That's the policy. That's the policies that are the Medicaid side of the house. So it's policy. It is it's I want to say it's all things Medicaid. Go ahead, Marcel.
Sorry, I just want you're just clarifying the acronyms, like what DHCFP is, Division of Healthcare Financing and Policy, or just what all these entities do?
Esther, is that what you need? Is just what the acronyms are, or what they do?
Yeah, because I think we all kind of have an idea. Thank you, but that just for once give us a legend so we know what you're talking about.
Sure. The DHCFP is Division of Healthcare Finance Policy. MCQA is Managed Care Quality Assurance, and the MCOs are the Managed Care Organizations.
Okay, maybe I don't know. Maybe somebody else doesn't know, but who does the MCQA?
Those are the MCQA they are DHCFP. If somebody is on this call who can explain this better than me, I invite you to jump in. But the MCQA are DHCFP staff who work. Oh, Tanya, perfect.
Good morning. This is Tanya. I'm in the Managed Care Quality Assurance Unit. And what we do is we monitor the contracts for our managed care organizations and ensure that they're in compliance with the contract for both state and federal regulations. We also help with facilitating between different entities with our managed care organizations.
Thank you, Tanya.
Absolutely.
Okay.
Could I ask a quick question about that to Ms.
Sure.
Tanya? So
Certainly.
knowing that the MCQA is responsible for that, does the managed care email go to the MCQA staff?
Yes, so for the managed care at dhcfp.nv.gov?
Yes, ma'am.
Yes, it does.
Thank you.
Mm-hmm.
Okay. Just giving some additional updates. Susan compiled a list of the web announcements because there have been plenty of web announcements that have been published for provider type 93. And we just thought it would be nice to be able to share that with this group just so that you are able to keep track of those if you need to go back and look at any of them for reference. So I've provided the list of web announcements in the agenda. Susan?
I'm sorry, I don't mean to backtrack, but I was just getting numbers together for the accomplishments, agenda item number 2. And I wanted to share this with the group because I think it's very exciting. I know we've only been live with PT93 since July 1st, but as of today, we have 26 enrolled groups and 16 pending the final review process for the PT93 groups, and then 26 enrolled individuals and 26 pending final review for PT93. So I was pretty excited about those numbers this morning. I wanted to share.
So 26 enrolled groups, 26 pending final reviews, and something else, Susan, you said?
26 enrolled, 16 pending for groups.
16 pending groups. Okay.
And then 126 enrolled and 26 pending for individuals.
Okay.
So I know the process has been extremely frustrating for many of you as I've worked with you. So I just wanted to say congratulations. It's pretty exciting.
Thank you. Susan, if my notes are incorrect, will you drop that to me so I can correct that, please?
Yes, ma'am.
Okay. Thank you so much.
You're welcome.
So it is possible. Yes, it's been arduous. There's been some struggles with it, but it is possible. So thank you for sharing that. Okay. Gainwell hosted a WebEx prior authorization workshop on the 7th at 10 a.m. That workshop was recorded and will be uploaded to the YouTube channel as well for those who were not able to attend. From that, I wanted to address some questions, and I think that this is a good place to address those questions. From the prior authorization workshop, there were some questions that were needed to be posed to the group. One of the questions was, for groups, not all facilitators are licensed and they can still provide services. For example, we have psychoeducational groups that community partners provide or staff that is not licensed. The answer to that question is we've reached out to CASAT for further guidance. We've had a short phone call this morning. I have not yet been able to meet with Sarah or the leadership team from DHCFP to on discussion about how to proceed and move forward. But we did reach out to CASAT. We do. There is further discussion that is forthcoming. The second question. Let me pull those over here so that you guys can read the questions with me. The second question was about providing 25 hours per week for service. And then there was a question, what's the difference between 25 hours of clinical versus 10 hours of clinical counseling? Again, we reached out to CASAT this morning and got some clarification. We just need to come together as a behavioral health team and provide further direction, but we did reach out to CASAT this morning. The question, can you bill for weekend days where there are not clinical services? Again, it's all the same. These are all kind of the same. They're the questions that are kind of in the same vein, and I understand why they were being asked. And because it was a very quick conversation, but we addressed all of these questions this morning. And I know Mark also spoke with Sarah. I have not yet spoken with Sarah this morning, so I need to get together and I'll send out direction. We can address like what we're going to do, how we're going to address this going forward. And then for authorization, are the MCOs able to veer from the chapter? That was the recommendation, was to continue. If you have an MCO specific question, continue to send your answers or your questions to the managed care inbox. And the reason for that is because that gives DHCFP, we get to understand what your concerns are, and that helps inform how we write contracts with our MCOs going forward. And so the other thing that Sarah wanted me to share is that all MCOs have an MCO appeal process. So if a decision is made, something that you don't agree with, she said she encourages you to follow the MCO appeal process. Okay. Those are the updates that I have from our last meeting, information that I promised that I would bring back to this group. So I'm going to open this up for open discussion for questions that you may have, things that you need clarification on. Angela, go ahead.
So just kind of based on your last statement, you said about the MCOs having an appeal process. So I was the one that posed that question. I did send my concerns up to the MCO. My concern is that we submitted an authorization. We asked for a certain amount of units. We received an approval back for a completely separate amount of units. And all it says is, congratulations, we agree this is medically necessary. We're only going to give you this. There was no acknowledgement that we requested other amount of units. There's nothing written on the form on how to appeal it because in their eyes, they approved it. So I'd like to get more information on that, please.
Okay.
I think it's important to add the amount that was approved, Angela, so that folks that are residential providers are aware of what's to come.
So what West Caris decided to do is based on all the conversations that I've had with each MCO individually, they're pretty much under the understanding that they're going to give us maybe initial, we will request 14 days, and then we would need a concurrent, which again is different than the chapter says. But we were like, okay, we'll try 14 days. We got an approval for 5 days with no reason why we only got 5 days. They say, we agree it's medically necessary. They send a copy of the letter to the client, and that's it. So I do have a call with them later today because, in my opinion, I think that they're not set up and that it was triggered incorrectly. And, you know, maybe what I'm running into with all the MCOs is nobody's ready, nobody's set up, everything's being processed incorrectly. So that's just, there's no way we will survive if we're getting 5 days at a time. We have 126 residential beds. There's absolutely no way. So I'm really hoping it was a fluke, but that was the reason behind that particular, which is the only authorization we've received so far out of 9 that we've submitted.
Angela, was that level of service 3.7 or 3.5 or 3.1?
3.1, Susan.
Okay, so that should be 30 days according to policy.
Yeah, and what I would like to just add to that is just want to make sure that everybody's prepared for the amount of administrative burden that's going to come with the authorization for 5 days with continued auths at a potential 100 bed facility or even a 15 bed facility. If you're doing continued authorizations every 5 days, it's going to be a significant increase in your support staff requirements. So just be aware.
So Angela, how long did it take you to get the 5 days?
Believe it or not, we got the approval within 24 hours. But when I reached out about asking about it, I get the runaround. So no matter who I talk to on the phone, they won't help me. So now I had to actually set up a call with Carelon to discuss why we're only getting 5 days.
And again, I think it's a learning process on our part because again, it's important to ensure medical necessity, the communication's correct, that in the documentation to support it, to justify the request, if you will. So again, it's a documentation thing to ensure that as well too. So we take some, we bear some accountability in ensuring that, and we are ensuring that we're looking at that as well. So you just have to make sure that you're speaking the same language as the payers are and the individuals that are reviewing the authorizations, either prior auth or continued auth, to ensure that I would imagine they're using the interqual or right, one of those to govern against the medical necessity justification for the auth request.
I believe that we are following, well, Gainwell is following the ASAM criteria as well as interqual.
Right.
So it's learning. I did just get another approval from Silver Summit, but for 14 days. So it looks like Silver Summit is processing adequately, but I will tell you guys, even though policy says 30 days, pretty consistently, the payers are only willing to do 14 days at a time.
Okay, so there are some of us who've gone to longer term treatment and have found out that it's more effective. So what does this actually mean? We're going back to the days when it's less than 30 days and, it said it meets medical necessity, but it's kind of like smoke. What is it that they're really drilling down on? So what is this going to mean? Are we going to have to shorten our stays that we found more effective? And okay, so where do we go find how they determine what they consider. Each MCO considers medical necessity, because it sounds like we're not quite sure.
This is Marcel. I have a question, just coming from not the outside, but just not as familiar with the processes. But when you submit for a prior authorization and you submit your request, when they return that request with the approval, and maybe Susan already answered this or it was answered in a different meeting, but do they have on there like, this is the reason why it was a shortened request, or this is your appeal if you don't agree with the amount, even though it was approved? Is there anything on that letter that comes back to you? I'm just curious of how the letters come back.
So yes, Marcel, that was our concern, was that we submitted, normally when you submit, you ask for, 20 days or whatever for IOP. If they will not, if they don't approve the full amount, they come back and say, you requested 20 days, we're going to give you 15, and this is why, and they kind of lay it out.
Oh.
The reason that I think this is a glitch is because the approval came back with only 5, no acknowledgement that we requested more, no reasons that they did less, nothing, which I feel is just, it's incorrect. It's not the way it should have processed. So I'm thinking that the code that they have in their system isn't aligned properly, or somebody did something wrong, and that hopefully this is an error. That's my hope.
Okay, and these are the letters coming from the MCOs. They're not having the same explanation at the bottom.
So far, it's just Anthem that we've had this problem with. Like I said, as I'm on the call, I got the Silver Summit approval, and it's beautiful. It matches exactly what we requested. So no issues there. We haven't had anybody present from Molina yet, and we haven't had a fee for service yet. And HPN's all pending. So they're kind of sitting on it for a minute. They're requesting, they need us to put an attending physician on there. So that's the reason that one was upheld. But we got that turned around. So we have to wait and see what the other MCOs do. Right now, it's Anthem is the problem.
Okay.
So if the policy's 30 days, why are we only requesting 14 days? I mean, we can talk offline about that, but we should be requesting the 30 days as per policy.
When I talked with Anthem, they said they will only do initial 14 days. I got that in writing.
That's okay. We would submit for 30 days according to the policy, and then they can approve for 14.
So my
Hopefully the
fear is
state
that
is-
if we request too many days, what it turns into is a denial that turns into a peer-to-peer, and they will only do a peer-to-peer with high-level physicians. So it actually it's more of an administrative burden rather than asking for a little bit less and hoping that gets processed. So I'm trying to, because of how high of an administrative burden this is, how much time it's taking, and all the additional steps we have to take, we're trying to find a happy balance.
Well, what we're hoping that the state, based on the comment earlier of verifying that the policy was 30 days, we're hoping that somebody from the state is going to communicate that with the MCOs. So we don't want to get into the habit of, I mean, if it's only medically necessary for 14 days, that's perfectly fine. But if you're looking for 30 days according to the policy, we should be submitting for 30 days. If it's medically necessary. Again, I'll make that clear, but is somebody on from the state that would comment on whether or not we intend to have communication with MCOs about that policy for 30 days?
We do, and I'm looking at, I think only Tanya right now is from our MCQA unit at this time, but I'm hoping, Tanya, that our next meeting that we'll be able to have someone present from each of the MCOs, because I think that it'll be important in order to answer the questions. I thought we kind of solidified that from the last meeting, that representative would need to be on to answer their particular MCO question, or we'd be able to take those back individually. But I will clarify, because we're on the behavioral health side and we're trying to bridge the gap here.
Marcel, this is Tanya. Yes, they will be available at the next meeting. Unfortunately, they are in audit reviews this week with us, and so that's why they're not available today.
Okay, thank you.
Mm-hmm.
So yes, Dr. Engel, we will address that for you.
Thank you.
You're welcome. Esther, I wanted to go back to your question. You said, what does the less than 30 days for authorization mean for treatment? What do each of the MCOs mean when they say medical necessity? So I can take that back to the MCOs as well and ask if they have something, unless MCQA has that knows that definition off at the top of their head that they can share with. But I will take that back and request to see if we can get what does medical necessity mean to the MCOs, get some clarification on that definition.
Yeah, because it's pretty squishy.
Yeah,
And
I mean,
this is where we're all going to get hung up. See, what I think right now we're all there looking at smoke. And it sounds like the MCOs are totally unable to stop us. And what we have to do is get the play cards so we know. And,
yeah.
I mean, Angela was right. It's, we think we know what we're doing, we send it in, and then it's totally different. So how soon can you get that answer, even though they're in review? You know what? We're looking at existential issues here. So how soon can we get these answers?
I will send this out today to the MCOs. I can't answer how long it'll take them to respond, but I will send it out today after we get off of this meeting.
Thank you.
Sure, my pleasure. Good morning, Mary.
Good morning. Thanks, Beth. I
Of course.
have a lot of questions, but I'm going to start with, is it possible, it's disheartening to me that we don't have any MCO representation on this call, because you guys are doing your job, but they are denying everything and roadblock after roadblock. All of our emails to them getting clarifying questions are just going ignored, unanswered. Is there a way to schedule a meeting where the MCOs have to be present and the governing body that is in charge of them is present to hold them accountable with all of us, where we can have these conversations?
And
Go ahead.
no, sorry, Beth. I was just going to put in. It's just evident from this meeting and the last meeting that MCOs, we need presentation, and I know it's discouraging and it's kind of hard to have these conversations when we're missing a piece. So we fully acknowledge that we need contact with the MCO. So that is going to be the goal for the next meeting, either this meeting or a separate meeting schedule with you all. Because again, we can't answer some of those questions, and we apologize, but we will. That is going to be the goal for the next meeting, to have them present for most of these MCO questions.
Okay, you guys have to understand from our point of view that you guys say this is what they're going to do, but they're saying, nope, sorry. And the administrative work behind trying to fight that is just ridiculous. So please, if you guys can really work towards not only just having them on the call, but whoever's governing them on the call, whoever can hold them accountable, because we're all getting different stories from all four of them. And it just would be good if we could hold them accountable with their boss, basically. The other thing that I just want to, and Beth, I really appreciate that you took this to CASAP this morning, but there's a huge difference in residential treatment with 25 groups if they're all licensed, credentialed clinical process groups versus all the psychoeducational, workforce development, all of those. And right. I'm curious what the other residential programs, we're still pending approval on provider type 93, very frustratingly, but I'm assuming that we're going to be able to at some point back bill. And for Angela and all the other people who are getting these prior auths, they haven't had to yet submit to see if they're actually going to get paid. And there's a huge difference between 10 clinical process groups and 25. And so we need the answer to that question today, basically, because these guys are going to be submitting for all this work they're doing, and it's going to get denied if they're going to hold them accountable to 25 clinical process hours. And none of us are going to get paid anything for January or until we get this answer. So that, in my mind, is a very pressing. I mean, we're already halfway through January almost, and this has been in the works for a year and a half, and we can't get it hasn't been decided if it's 10 clinical hours or 25 clinical hours. That just seems crazy to me.
Mary, I agree with you. And it was a shock because when we developed MSM Chapter 4100, CASAT was on that call with us, and they looked at the manual, they looked at the policy before it went through the approval process. So I don't, I mean, we lean on CASAT, right, to be the clinical entity for the liaison, if you will, between the providers and policy and what that needs to look like. So I appreciate the fact that that got brought to our attention. And we did speak with CASAT this morning. CASAT said what they say is an alignment with you. So Mary, what we need to figure out on our end, and this is the discussion between Sarah and I, and this is full transparency, is that we have to figure out what we need policy to say. I have received a recommendation of how to fix the language in policy to align it with CASAT, with your SAPT for your SAPTA certifications through the division. But that's a decision that has to go above my head. We have to have, and then everybody knows that making policy changes, it still has to go through, it has to go through open meeting law. So it has to be posted. It has to be submitted 60 days. I mean, we can't do anything, and we have to have it posted for 60 days before we can go to public hearing to make the change. So I don't have, as much as it hurts my heart to tell you, I don't have an answer for that. I don't have an answer that I can give you about how to make it work. I'm hoping that that your clinical directors, maybe the clinical staff, can help you get creative on how to make those. I don't know. I don't know, but yeah. I do need to have the discussion with Sarah about what do we need to, I need her approval to change policy, and then what do we do in the meantime? Because that's not for that 60 days, what guidance can we give to the providers while we're waiting for the policy to be updated? So I hear you, I understand. And that when this became a light that was an issue, I said, oh my goodness. So yes, it is urgent. Okay. And I do hear you.
Well, I appreciate you, Beth, and I know you've worked hard on this piece. I guess ultimately what it boils down to is, my concern is, I believe that eventually it's going to align with what CASAT and SAPTA have been for all these years on what flies. But ultimately, I feel that the way it's worded out of the gate, you guys just gave all 4 MCOs the ability to deny every single claim that we submit for residential, even with prior auth, because they're going to go by the letter of the law of that 25 hours. And they now have license. Because those of us that are providers, Medicaid denies first on everything when you submit a claim, and they now have a license to, based on that language.
Oh, and that was not the intention, which is why
I know.
When we went through the policy, go ahead.
I know that it's going to take some time to get that worked out and the verbiage changed, and I understand how you have to post it in open meeting law, but this is where we're going to need the people who oversee the MCOs holding their feet to the fire, not to deny all these claims until that verbiage gets changed.
Okay.
Can I just add just a quick reference to the policy again for future, and I know this is going to be an immediate concern. I just encourage everybody to continue, if you haven't gone in and fully looked at, because it's been posted, I believe, since July, just to find, when we go to policy, like Beth is saying, it takes a little bit of a process to make these changes. And if we're going through, and if there's other things that need to be updated or changed, it's easier to do some of those big fixes all at once rather than do them in piecemeal. We know it's going to be a continual changing document, but if you know that there's already things in there and you can point out other things, we don't have to go back and wait as we go through the process, because it does take a little while for the state. So I just wanted to encourage everybody to reread 4100 if you haven't done it again recently, just to kind of pinpoint some of those things, because we're relying on you as providers actually doing the work to know if it's not meshing a little bit. So I just wanted to put that out there.
Right, because it doesn't do us any good to write a policy that's not user, or that's not applicable to the end user, right? And that's the agencies that are doing the work for the purpose of getting the services to the clients. And so I think some of the providers on this call I've worked with very closely and can attest to the fact that if you have questions, if you have recommendations, I am willing to hear those and take those forward and make changes where I can, because the recipients need you to be able to perform the services, and that requires Medicaid to do their part as well. So I encourage that communication for sure. Rochelle, I see your hand is up.
Oh gosh, sorry. It's not anymore. I was just wanting to make the comment, but someone said it, that we can't just have the MCOs there. We have to have state staff who holds them accountable there very specifically. It can't just be the MCOs and not the people who hold them accountable, because it does feel like all four of them are doing different stuff, and we're left in the middle of this not getting paid for these vital services. So
agreed. Thank you, Rochelle. Angela, I see your hand.
I wanted to piggyback on what Mari said. So I've also read that in the chapter, and Beth, I believe you and I talked about it. So our interpretation of the 3-5, 25 hours clinical services versus the 10 hours, on the next page, it lists all the covered services. So we understand the 25 hours to be structured services. And of that 25 hours, 10 being, and it says here in the chapter, clinical counseling, which if you look on the next page, clinical counseling are individuals and groups. So when you think about it, that's 2 hours of clinical groups or individuals 5 days a week, with the weekends being structured activities that address all of the items that are listed in here. That's the way we understand 3.5, but I wanted to point out that 3.1 has nothing like this. 3.1 is very general. There is no set amount. It's a span of time. So that's also where I agree with Mari and with Rochelle. The MCOs are going to try to find some wiggle room with the way that this is worded.
So let me pose this to the group as because this is, again, in full transparency, when I was speaking with Mark and from CASAT this morning, he said that the division, right, when you're certified through SAPTA, part of that certification process is they're looking at the hours that are provided, like they're making sure that the agencies are performing services in accordance to ASAM criteria. That includes the amount of service hours and the type of interventions that are being offered, correct? So the recommended language is to provide services in accordance to criteria as set forth by the division. That kind of leaves it blanket and open up to SAPTA or CASAT then to have that oversight of the clinical services. I agree with that, but I have some reservations about what are MCOs going to do with that information? What is SIR going to do with that information? Does anybody really know what that looks like? So that's the discussion that I need to have with Sarah. And I'm sharing that with the group because if you guys are out there doing the work, right? You have been doing this for a long time. You guys are the experts in this field. So if you have recommendations of what it should look like, what you would want it to say, if you want to send the information, those recommendations to me, I can take that as we're in this process of trying to fix this to make it work for you. I'm willing to hear those. I'm willing to hear what you would want it to say.
I wanted to also add that I think Mari or Rochelle or Esther, somebody brought something up about the claims. So we've pretty much received confirmation from all the MCOs that they are not going to be ready to process claims and that all of the claims will be delayed. I don't know too, because I know Susan's on the call, is fee for service kind of in that same boat? Because I know you guys won't have your codes or rates loaded until like the 20th or so of January. Do you think that we will see delays there as well?
That's only if this is Susan, sorry. It's the only for level 3 codes, those 3 codes that were just approved by CMS. I think we got the approval in October, and work began then to get those rates loaded into the system. So the codes are available for you to request the prior authorizations, and you can bill your claims. However, the claims will suspend until they're supposed to be released and ready for live production in, I think it's January 21st. So you would see them on that week's financial cycle and the following week's remittance advice. So towards the end of the month.
Okay, that makes perfect sense for fee for service, but for the MCOs, like for example, we still haven't received our contract back from Carelon. I had been asking for a contract for months before this went live, and because I just got it right before the turn of the year, they are now saying that we have to give them 30 to 45 days to load it into their system, and in turn, they won't process any of our claims. In addition to that, I've received information from the MCOs that if we bill all under one coordinating QMHP or coordinating provider, that it will trigger an audit. So these are all things that with the way that we are set up to bill, set up to provide services, set up to get authorizations, where we're just going to run into so many barriers, administrative burden, and delayed revenue that it may completely cripple some of the providers on this call.
I think, Angela, that's why the MCOs asked for, when DHCFP met with MCOs and MCQA at the beginning of December after the meeting, MCOs were provided with draft billing guides for the residential codes, so that MCOs said that at that point they could work on the transition, because I that's not really an answer for your question of will they be ready, nor is it an answer of probably any of the concerns. But I think I share that to just show that fee for service is attempting to work with MCOs so that we can help alleviate some of these big delays that are going to be financial burdens to the providers. So the only thing that I can do is, I'll take this information back and let them know that all of the MCOs have told you, even though we gave them those draft billings and they've told us that they would work with transitioning based on the billing guide, the drafts that we provided, that they're still not going to be ready to process claims. So what does that mean? How long will that take? What does that look like for you?
That would be really helpful. Thank you. I think the last question I had, and I know, Beth, you were working on this, but we've identified that there were some missing codes in the new provider types, particularly H0015 with 701 and 703, and H0035 for our QMHP 14300s. Do we have a status on when that'll update? And are the MCOs going to be held accountable to reprocess back to August or whatever when this was identified without running into timely filing?
So that PDR has been submitted. We just got an update yesterday for a request to push that out for 2 weeks. So there are two big PDRs that are going right now. And a PDR is essentially it's a work ticket. So it's how Medicaid gets codes changed in the system anytime there's system work that needs to happen, right? And there's two big work tickets that are going right now, which were simultaneous. One is uploading the residential codes, and the other one is mapping the 80047 to which, Angela, you didn't ask for that one, but the 80047 to the interns, and fixing the 80015. The 80015, that one didn't need a PDR. So let me address that one for a second, right? So Medicaid can't update. I can't give you guys an updated billing guide that shows the code corrections until the system work has been completed. They are drafted. They are ready to go. But yes, when I submitted those work tickets, I requested the MCOs to do an automatic recycle. So they are anticipating that for both the residential codes and the 80047. To your question specifically about the 80015, we were working with rates. I will get a status update. I don't have one. The last update that we meet with rates on a weekly basis. And when we met with them this week, it was they didn't understand why 80015, which is mapped in the system, isn't on the fee schedule, so that there's a disconnect somewhere. I don't understand it. That's above my head in a different department, but they are aware of it. They are looking into it. They needed to get some of their additional team support involved in that correction. I don't have an update for the 80015. I will ask specifically. I can send that out and let you know. But yes,
Great.
we are aware. We are working on it.
And the same with 80035 for 14300.
I want to say yes. Give me one second. Give me one
So
second.
those are the two of them that the MCOs are not processing, and it's adding up really, really fast. And so I have to explain back to my accounting what's going on.
What is H0035 again?
PHP.
That's the PHP, and this is for the
QMHP.
300.
Yeah.
Oh, update fee schedule for 80 needs to be Noel. Oh, yep. Yeah, there is a note on that. Yes, that's the one that we were talking about. Is the 80035 needs a rate line on the PT 14 fee schedule for 14300s. That's the one that Noel is working on fixing. I think I said 80015.
Yeah, there's two of them.
My
Those
bad.
are the
Okay.
two big ones.
Okay, so let me go back to the 80035. I'm looking at that one in my notes. My apologies. The 80035 being mapped to in the system to the 14300s, it already says that they should be able to do it. We're not quite sure where the disconnect is in the system, but Rates is aware. They are working with their higher internal people to get it fixed. I can reach out to them and get an update for that. I don't know. Tell me again, Angela, the 80015 question.
That one is not mapped to CADC and CADCI 701 and 703. It was missing on the rate scale.
That is the one. I'm sorry. Then yes, that was the one. I called it 80047. It is on that same PDR. So that's the one where they've requested a 2-week variance. So it was originally going to come out at the same time as the PDR with the residential rates, but because I don't know why, we just got a request that they need to, in order to be able to continue to prioritize and stay on track with getting the residential codes loaded, they've asked to allow a 2-week variance for the 80015 and the 80047 to be done. And so, but yes, both of those have been indicated that there needs to be a recycle.
Thank you so much.
You're welcome. Okay. What other questions, comments, concerns, things that you would like me to address that you're not being able to get answered? Okay. If we don't have any other questions, I will give you 10 minutes of your day back, but with my sincerest gratitude that you are able to rearrange your days, your mornings, and join us and engage in this conversation. I think this meeting, these conversations, these are detrimental conversations to this community, and I appreciate being able to come together, advocate on your behalf, and getting the change that's necessary so that we can get the services to our clients and get you paid for the services that you're providing. So I appreciate this forum. Our next meeting is scheduled for February 13th at 9 a.m. In the meantime, if you have questions, you can reach out to me. The behavioral health inbox is monitored, and if something comes through there, it'll get routed to me pretty quickly. So if you have, that's how you can get a hold of us. Susan has been gracious in being able to share her time to help people with enrollment questions. So if you have enrollment questions or application questions and you haven't reached out to Susan, please reach out to Susan. She can help you. She's a wealth of knowledge.
Thank you, Elizabeth. We appreciate you. Happy New Year, everyone.
Thank you, Beth. You're the best.
Happy New Year, guys. Thank you so much. Have a great rest of your day. You're welcome.
Thank you.
Thank you,
Bye.
bye.
Bye-bye.
Thank you.
Bye, Lana.